Hello and welcome to Talking Health. I'm Mike Gilliam. Over the next half hour, we'll look at the marketing of medicine and how it's changed over the years. We'll examine the big business of marketing prescription drugs, and we'll take a look at medical and surgical tourism. You'll hear from patients who have traveled out of the country for medical care. But first, we'll talk to the president and CEO of Montefiore Medical Center, one of the largest and most successful hospitals in New York, about its marketing efforts and the ability to cut the number of readmissions. Montefiore Medical Center has been ranked as one of the best hospitals in a variety of specialties for 2013-14 by U.S. News & World Report. Its president and CEO, Dr. Safyer, sat down with me to talk about the marketing of medicine and the medical center's many successes. Pioneer ACO, okay, it's been very, very successful. Talk to me about that success and how it all worked.
Pioneer ACO is a program that came out of the healthcare reform. It's actually in the bill. And there's a section of CMS, which oversees Medicare and Medicaid, which was encouraged and empowered to do innovation. And their innovation is focused on moving the fragmented healthcare system to be a more integrated system. And in addition to integrated and efficient as it provides care, they want it to be more integrated with the payer so that the fragmentation of our current system can begin to be overcome. So the Pioneer ACO is one of 250 experiments that are going on in the country, or pilots that move the system in the direction that I'm mentioning. But 32 of the 250 participants are in this Pioneer program. And Montefiore was the only one in New York State, and in a version of the Pioneer which had the most downside risk and the most upside risk. So you had to be ready to be able to be a pioneer. The pioneer literally means that you've been out there doing this for a long time.
And you guys have been working on this for what, 15 years?
15 years. The attention and the spotlight has been on the pioneer. But in fact, we've been doing this for 15 years, and currently at Montefiore, 60% of what we earn is in prepayment or capitation or shared savings. So it's already in this arena. This is just a slither, like a slice on top of what is a very strong foundation and a big commitment to move and change the healthcare system, okay? So the results just came out on this Pioneer program, and we came out top in the country. And there was, in our program, 20,000 individuals who were in the fee-for-service Medicare program in the Bronx that were moved into this program. And we had gigantic savings. We didn't just bend the curve, the upward climb of expense for healthcare in this country, but we literally went below what was projected to be the spend. And we performed or contributed, of all 32 programs, 700,000 individuals in the program, we contributed 25% of the savings.
How much money did you save?
We saved $24 million for the federal government, for you and me, because we pay taxes. And we provided better health care, better quality, and in sharing those savings with the government, they're going to be very kind to return to us basically a bonus of $14 million. We split the savings, and we're going to use that money to continue to build this model, hire more social workers, nurses, doctors to manage people's care. So here's the punchline. The current system is rewarded for putting you in a bed or doing a procedure on you. There's no mystery about that, okay? In my mind, the system should be turned on its head. You should be rewarded to keep people well.
Let's talk a little bit about medical marketing.
Marketing has, as you know, being in the media, many audiences and many faces. I think rightfully so, or understandably, when people think of marketing, they think of an ad on TV or a piece on radio. But marketing is something that is embedded in our culture. Marketing has a lot of components. It's branding. It has a lot of goals: recruitment, fundraising, and education. We live and work in the poorest, basically city, because the Bronx has 1.5 million people. It would be the 6th largest city in the country. 1.5 million people. It's probably the lowest socioeconomic status in the country, the biggest health challenges in the country. We use marketing locally to educate people, to get them to come in and have their blood pressure checked, get them to come in and make sure they don't have diabetes and so forth. So we're using marketing for multiple reasons, okay? Now when you talk about the TV ads, and we have them, and you talk about the radio pieces that we purchase, those more have to do with getting the Montefiore name out so we can continue to recruit the very finest doctors from all over the country. When I'm looking for a cardiac surgeon or a neurosurgeon or some kind of specialist, I want to get the very best person that I can get. By marketing who we are, what we do, how we educate, how the doctors of tomorrow, how we have medical students here. We have 1,300 interns, residents, and fellows training to be the doctors of tomorrow. We want to get the very best. So getting our name out there is critical and important. We have a children's hospital here. It opened 11 years ago. It's one of the top ones in the country, serving the poorest borough in the country, a very young borough. There's 500,000 children in this borough with lots of needs. 2/3 of the borough is obese. We have children who are 10 and 11 years old who are, by your eye, grossly obese. I'm not saying heavy, obese. And they're getting diabetes by 12 and 13 years old. So we need the resources to heal the children that have already been affected. We need the resources to prevent the next generation from going down that way, and we need to get our name out there, and that's what we do.
So that marketing also is very effective in getting these people in for treatment as well. So it does help patients.
Absolutely, because as you know, this borough is very diverse with lots of cultures, different cultures. It's a rainbow of cultures. And those different cultures think about health differently from each other. They think about the system differently than you may presuppose. And we have to break through that barrier. Sometimes there's taboo about coming into the system or getting care or comfort with that.
How do you reach those different cultures, though?
We're in all the local newspapers. We're on the bus stops, and we use handouts. And it's a very meticulous approach to reaching people where they are, in their churches, in their community organizations. We need to reach those people.
So do you have a department that just does this?
Yeah, we have a department, absolutely. We have a marketing department.
Mm-hmm. And they spend their time dealing with radio, television in different languages?
Yes. Oh, yes. We're hitting the languages, yep. And the cultures, which are different. We actually don't view ourselves as a hospital, despite the fact that we're the 6th biggest hospital in the country, with 100,000 people that come in, and most of them leave well and better. But that's not how we define ourselves. We define ourselves about as much about our primary care, our community care. We're in 50 sites where we're just doing primary care. We do 3.8 million encounters a year, of which only 100,000 are hospitalizations.
Readmissions. You've cut readmissions a great deal here. How did you do it?
Well, the capitation program and the prepayment program, to me, is, again, that's where when that's your focus, everything falls together. Now, there's a lot of discussion and dialogue about some other efforts that come out of the Affordable Care Act, for sure, which have to do with penalizing readmissions, okay? And, that's the stick. I like the carrot. So the carrot is, if you're capitated, if you're in a prepayment, a comprehensive payment, the reward is obviously, the biggest expense is always a hospitalization. People don't like hospitalizations anyway. Why should they? If they can be prevented, you know. So we're always trying to get people at the level of care that they require at that moment, at that time, at that phase of their, I call it health, not illness. I mean, you want to get them in the right setting. And sometimes, you know, a hospitalization is necessary. And we're going to admit you if you need to be admitted.
I have to ask you this. What do you think about this medical tourism?
Well, I love it when people come to the Bronx.
Right.
So it kind of goes both ways, doesn't it?
Right. Yeah, absolutely.
Okay. So I'm well aware that there are people shopping and traveling to other countries to get care, especially certain kinds of things that, if you're paying cash, are more expensive, like plastic surgery or certain treatments and so forth. So people are going to India and they're going to China and they're going to South America. There's Mexico, no question about it. We have the best healthcare system in the world. I mean, we have the finest medical schools, the absolute best providers. People should be coming to us, and we, that's happening on a regular basis here. So people are traveling here. I'm much more familiar with the people that are coming here, and they come here for care that's not available where they live, but in general, those people are well-to-do because they're educated and they can travel here and they can come here. So we're regularly taking care of people from all parts of the world.
Great. Anything else you'd like to add?
Well, I think that where we began is very important to me, which is our ACO or a pioneer ACO, and it's important to me because I really believe that it can't just be Montefiore out there on its own. I believe it needs to be all of New York City, all of New York, and all of the country moving to change healthcare because it's not sustainable that this country would spend 18 to 20, soon 20% of its GDP on healthcare. It's just not sustainable. There's some moment in the future, if not the present, where that's going to end. So we need to innovate. And just as we've innovated in terms of providing the best care in the world, we need to innovate on how we actually deliver it. And I'm not saying that what we're doing here with our ACO is the model for every sector of the country, but I'm certain it's a model for the majority of the country, especially urban settings and settings that are struggling, and especially struggling in this economy. So we're going to have to do better with less, and I think this is the way. It's always about quality, it's about wellness, but it's also about stewarding how we use the resources that we're given by society, by you and me.
The public most often sees the marketing of medicine in magazines and on television. It wasn't until the 1970s that the government allowed the advertising of prescription drugs on TV. But now, if you think about it, you can probably name more than a handful of drugs and maybe even recite what they're used for and also the list of side effects. The marketing of prescription drugs is growing every year. Melissa Noel takes a closer look at this booming business.
There's Tamiflu to treat influenza, Claritin D for allergies, and even Latisse for longer eyelashes. These are just a few of the prescription drugs many of us know by name thanks to advertising.
Your doctor about Tamiflu, prescription for flu.
Patients come in all the time requesting the drugs they've seen on TV.
Dr. Baron Lerner is a general practitioner at Bellevue Hospital. Although many of his patients may know the names of the drugs they want, they don't always know all of the facts.
It's a mixed bag because on the one hand, I think patients can get information in that way from drug companies that they might not get other ways, but because they're getting it through advertising, oftentimes the advantages of the particular product get exaggerated and it potentially misleads the public.
The marketing of prescription medications on the airwaves, in print and online is one of the reasons drug manufacturers have been successful at getting patients to request their brands. But Lerner says patients must look beyond the sales pitch.
Just because you see something on TV and it has a better package or it's a better color and it has a cute name, it doesn't mean it's better. It usually means it's more expensive. And I point out in cases like that there are no studies, as is often the case, that this new drug is necessarily better than the old drug.
Last year, drug companies spent $27 billion on promotions. About $4 billion of that went to consumer marketing, mostly through television ads. But ads on TV and those in magazines aren't the only tools used for marketing in the industry. The majority of the promotional budgets, about $23 billion, is spent marketing directly to physicians. And a key component of that strategy is the pharmaceutical rep. Eli Lilly, the 10th largest pharmaceutical company in the world, says its sales staff use their knowledge and expertise to provide healthcare professionals with medicines needed to treat patients.
They have access to some of the latest research data to potentially inform doctors about new findings. They have the latest information about why this agent might work, what the side effects are, and what stage of testing it's in.
Lerner, in addition to his practice, also teaches medical ethics at NYU's Langone School of Medicine. He says there are some drawbacks to sales reps.
They come in and they have a focused agenda saying why you should, as a doctor, prescribe this pill. And sometimes the data doesn't show that their drug is better, and that creates a tension because the doctors feel maybe more obligated to prescribe something because this nice pharmaceutical representative came in and they spent their time and they brought potentially some food or gifts for the staff as a way of showing that their appreciation for being invited in, and there's a potential conflict of interest.
Possible undue influence by drug manufacturers on physicians has been a long concern at public hospitals like Bellevue, as well as teaching institutions. These facilities now have policies prohibiting interactions with sales reps. That same concern is also one of the issues that prompted Congress to include the Physicians Payment Sunshine Act as part of the Affordable Care Act. Key points of the provision stipulate drug manufacturers must disclose any form of payment or transfer of value, that the reports must be electronic, searchable, and easily downloaded, and that failure to comply will result in a civil penalty of up to $1 million.
Disclosure has been happening more and more, but this new act really takes it to a new level, and patients and the public are entitled to know what their doctors or their researchers are getting in exchange for doing their research.
Although some doctors and drug manufacturers are pleased with the new regulations, others are concerned it could stifle the research and development of new drugs. Beginning August 1, 2013, the Sunshine Act will require drug manufacturers to disclose any form of payments or gifts given to physicians, such as drug samples and even notebooks and pens. This information is to be publicly posted on the Centers for Medicare and Medicaid Services website. Melissa Noel for Talking Health.
Patients sometimes travel great distances to get medical care. It's been going on for years, with many coming to the U.S. for treatment from some of the best hospitals in the world. But large numbers of patients are reversing the trend and traveling across borders to get medical care. They're engaging in something called medical or surgical tourism. They're doing it for a variety of reasons. Now, some are looking to cut costs. Others are looking to get procedures that are for some reason unavailable to them here in the States. The American College of Surgeons has taken a position on medical and surgical tourism. They issued a statement saying that the college encourages patients to seek care of the highest quality. They encourage patients seeking elective treatment abroad to select accredited healthcare institutions. And they encourage patients to seek care from surgeons and anesthesiologists certified in their specialties through a process equivalent to that recognized by the American Board of Medical Specialties in the United States. Joining me now to talk about their experiences with medical tourism are Kathy Nettinger, Sandy Hardy, and her daughter, Corinne Hardy. Welcome. Kathy, why would you go to another country for medical care? Why did you do it?
I did it for a couple of reasons, Mike. Mostly because I had diabetes. My father had died of diabetes early on, and after running wound care centers, I knew diabetes is trouble. I wanted to reverse that, and it's not available in the United States. So I
What's not available in the States?
the diabetes reversal. It's a type 2 diabetes reversal surgery. It's called metabolic surgery, and it's something that's available in Costa Rica. So I found out about that and wanted to have that done for myself.
Okay. How about you, Sandy? You and Corinne went to Costa Rica.
Yes, we
Talk to me about that.
Corinne has endometriosis, and her endometriosis was causing constant contractions of her uterus, end-stage contractions 30 times a day. So by the time we finally made this decision to go, what she needed was a partial hysterectomy, which could not be done here in the United States for several reasons. Litigation issues, she was not married, she hadn't already had a child, and she didn't have cancer. So even though we contacted everyone from the ACLU on down, my daughter did not have the right to make that decision. She could change her sex from a female to a male, have a fetus ripped from her body, but she could not choose to remove her uterus to save her life. So when we found out about medical vacations, or medical tourism rather, we did that. We went and it was wonderful. It saved my daughter's life, and it was 5 years ago, August 12th.
How did you go about setting this all up? Did you meet with a facilitator? I mean, how did you get on to Costa Rica?
A doctor I worked for had told me about an expose CNN had done. I Googled it, and it was Clinica Biblica Hospital. I contacted them via email, the medical director there, who put me in touch with the chief of OBGYN surgery, Dr. Calderon. I got all of Corinne's records to Costa Rica. They reviewed everything. I explained her situation, and they said she's more than qualified to have that surgery done. We then were put in touch with a medical tourism company who helped us with transportation arrangements, as well as the director of the hospital, Bill Cook, also helped us to make all of these arrangements, because I was basically a babe in the woods. The only thing a travel agent helped with was airline arrangements. But for the rest, it was the director of the hospital, Bill Cook, who actually helped us and put us in the right direction.
While this was all going on, Corinne, how were you feeling? What were you feeling about this whole experience and leaving to go to Costa Rica to have this done?
At this point, it was my last option. Nobody in the U.S. wanted to help, wanted to do anything, and this was my Hail Mary. It's the only chance I really had at possibly getting this reversed and having a normal life again.
You were in tremendous pain?
Yes, about 8 hours of screaming, final labor pains, and I had about 30 to 40 a day.
And you had had other procedures as well?
Yes, I had 5 other laparoscopies for endometriosis.
And nothing worked?
Nothing worked. So we chose Costa Rica, and after speaking and making sure everything was up to code and everything was perfect, which it was, they were very accommodating, we went there and I came home and I'm still here.
Mom, describe for me the hospital situation that you found when you got to Costa Rica. Because a lot of people say, well, wait a minute, I'm not going to go to a smaller country. I'll go to the Mayo Clinic. I'll go to Johns Hopkins, but I'm not going to leave the country for medical care.
It far surpassed anything that we could have afforded to pay for here in the United States. Everything was state of the art. Corinne had a suite. Unfortunately, it was on the maternity ward, which was a little bittersweet. Okay, considering the procedure she was having. But I had a futon bed in the room so that I could stay with her 24/7. We had nurses at our disposal 24/7, a translator. We had computers so that I could communicate with my family at home. They bent over backwards to help us. I could not get that kind of care, personalized care, unless I had concierge care. That's what I had in Costa Rica.
What did it cost you?
The entire trip, including a 1-week vacation for my daughter on the coast, which she well deserved, The entire thing was $15,000.
And that included?
That included airfare, which we had to change at the last minute because her surgery got moved up sooner, okay? The hospital, the doctor, anesthesia, the hotel post-op, for which the hospital sent nurses for 5 days to check her vitals and to check her incision, which was pristine, okay? The transportation wherever we needed to go, special meals that they made arrangements for at the hotel for us because she was on a limited diet, plus the, the vacation that I took her to that also the hospital director helped me facilitate. So it was absolutely phenomenal compared to the fact that 2 years prior, or the year prior rather, she had had surgery by a specialist who did not take our insurance that was supposed to cure all this. And it cost us $20,000 out of pocket, and she was worse off in 6 months than she was to begin with. So yes, did it put me in a hole? Yes, but I have my daughter, and that there's no price on.
Kathy, was your situation similar to this?
It was. I've run wound care centers up and down the East Coast, and so I'm familiar with hospitals and so forth. And one of the things that was really important for me was to go and see it for myself. And when I got there, it was as stellar as everything I'd heard on the phone, everything that you've said. And everything from the RN care, which is unheard of to have full RN care around the clock at a hospital. Quite often here you have LPNs or aides assisting you with various things through your care, and it just was very state-of-the-art. The Clinica Biblica even has a feel of very traditional care. They wear the old nursing hats and have these really bright, vibrant uniforms. So just was a really nice feel, great place to go.
What was the outcome for you?
Within 3 days, I had reversed my diabetes and my high blood pressure. I was off of all of the injectables and the pills that I was taking for both diseases. And that meant a tremendous amount for me.
Okay. Sandy, Corinne, would you recommend medical tourism?
100%.
100%, or I wouldn't be here.
Okay, thank you. Fascinating stories. And thank you for a personal look inside the world of medical and surgical tourism. Now, one thing's very clear. The world of medicine is always changing, and a lot of the changes we see taking place are not only driven by research and development, but also by medical marketing. That's it for now. I'm Mike Gilliam. Thanks for joining us, and we'll see you next time on Talking Health.
This broadcast has been brought to you through a grant from the Commonwealth Fund.